sent out some information about it. People have been steadily expressing their excitement about it, and I am super excited to hear what Nina has to say. But I think the interest is a testament to how important this topic is and how we as women really do value our sexual health, but it can be put on the back burner a little bit in the throes of parenthood and with the physical barriers that come with pregnancy and the postpartum period. So that's what we're going to talk about, and hopefully delve into some really specific strategies you guys can use to help kind of get through some of those barriers. So Nina and I would like to start by acknowledging the Awabakal people, the traditional custodians of the land where we are speaking from today. We pay our respect to the elders past and present, and we extend our respect to any Aboriginal and Torres Strait Islander people that are joining us this evening. So
Thank you for that.
So excited to have Nina here. I'll let her introduce herself.
Hi, everybody. My name is Nina Booysen. I am a clinical psychosexologist, and I've recently moved here from Darwin. I've been practicing for about 12 years now. I'm also a mental health social worker, and my business is territory relationships and intimate health, as well as pelvic health Newcastle.
Yeah, and very well qualified in what we're going to talk about. And I am Erin Cuskelly. I've founded a business on women's health physio in Newcastle called Female Focus Physio. I've been practicing for about 15 years, but focused purely on women's health for the last 4 years, and primarily seeing pre and postnatal women. This is what I love talking about. So we'll try not to ramble too much, but if you guys do have any questions as we go, just pop them in the chat, and then if it's not something we've covered throughout the talk, we'll try and get time to go through that at the end. So feel free to interact and pop your questions in there, but just stay on mute so there's not too much background noise. So one of the things that we need to talk about is the prevalence of sexual issues, particularly in the postpartum period. So the most recent studies have shown that up to 91.3% of women suffer from postpartum sexual problems. So that's pretty much all of us. And we're talking about sexual problems, not just pain, but a lack of libido, a lack of desire, arousal, a lack of orgasm, the whole cohort. So we want to dive into why this is the case, why it's so prevalent, and what we can do to help to change that.
I think some of the studies show that a lot of that can resolve within 3 to 6 months. Women generally resume sexual intimacy 3 to 6 months after birth, but a lot of women don't, take up to 12 months. And some of those dysfunctions only resolve after 12 months anyway on their own.
Yeah.
But for those that don't, we need to seek more help and advice rather than, as women typically do, just sort of putting up with things.
Yeah, for sure. So we might start with pregnancy.
Yeah. Okay. Let me see if I can share the screen.
So one of the biggest reasons women come to see me as a physio is sexual pain, rather than the other intimacy side stuff that Nina is going to talk about. And if you've had an episiotomy, that's one of the biggest predictors of suffering sexual pain in the first 12 months. And if you've had a 3rd or 4th degree tear, it's not far behind that. So they're the biggest things that we're looking to try and manage early on. And this is where we'd like to dispel the big 6-week, you're fine, off you go, do whatever you want, because after 6 weeks, because if we look at tissue healing at that 6-week point, we're barely into the proliferation stage, which means that we are just starting to form a scar. And the scar itself is full of new nerve fibers, of tons of blood vessels. It's super sensitive, but it's also super stiff and immobile. If you have a look at the slide, it's not until, up to 2 years later that scar tissue actually starts to become more like normal muscle and skin and fascial tissue. So we need to help it along the way a little bit. And if we're thinking about an athlete with a muscle injury, then they're having acupuncture and massage and all these sorts of tissue healing things to help the muscle come from the proliferation scarring stage into the remodeling stage. So something that most of you guys, I assume, are beyond the 6-week mark. And from there, we can definitely start.
I'm just watching her show that podcast she's doing. Maybe.
Scar tissue massage. So
just admitting some more people. Just make sure you're on mute if that's okay, guys.
So I'll just do a quick demo with my little model. So if we imagine that this
Time to lay down.
the vagina. So we've got the urethra at the top and then this perineal tissue at the bottom. And so if you've had an episiotomy, the surgeon has actually cut through not only the skin and the perineal tissue, but your superficial pelvic floor muscle and potentially your clitoris. So what we want to do is start to get that tissue a little bit more mobile. If you see it yourself with a mirror, or if you have any skin on your body, it kind of puckers in a little bit. And if you have a look at the vaginal opening, obviously it needs a lot of mobility for penetrative sex. So using a natural oil or lubricant of any kind, you can start straight away from 6 weeks, and it's definitely not too late at 2 years postpartum to start working that scar tissue with a little bit of massage.
That's good to know, actually.
Yeah, so through the external perineal tissue, and then you can go internally up to sort of the distance of 1 knuckle and just put pressure there. One thing that I think find really helpful, if you feel on the side without the scar, and it'll feel like really pliable and soft compared to the side with the scar, where it will feel really stiff, you can actually hold down to a pressure that's tolerable but quite uncomfortable, and really try and breathe into it, relax into it, and as that becomes more comfortable, increase the pressure. So you're reducing sensitivity to the scar tissue, but also trying to actually get that scar tissue moving. So it's interesting though, if we look outside those women that have had 3rd or 4th degree tears or episiotomies, if you've had an uncomplicated vaginal delivery, you're actually just as likely to experience pain with sex if you've had a C-section. So why is that? If we think those tissues haven't been disrupted by a vaginal delivery, why would we still have sex if you've had a cesarean section? And again, it does somewhat come back to the scar. So if you've had an incision through the skin, the fat, the peritoneum, the fascia to the uterus, all those tissues usually glide on each other really nicely. And the uterine scar can have a tendency to kind of adhere to the upper levels. And we know with penetrative sex, we need a little bit of movement in the cervix. And so again, if you have reduced mobility of the uterus and the cervix and things just aren't moving very well, women tend to experience a real block with penetration and a lot of discomfort. So again, plenty of scar massage through the abdomen, doing lots of nice mobility exercises, hip opening stretches, yoga stretches that help to get that scar and that tissue moving, can be really, really helpful, because it's quite common to get into a bit of a pain and fear protective response.
Absolutely.
And if anything, things become stiffer and less mobile. So we really need to move those tissues.
We were talking about that earlier about pain, and I was mentioning that there was a study that was done in America with 21,000 women, which is a huge sample, and they were asked as to what they measured was a satisfying sexual encounter. And you would think it was a lot of exciting things, but it wasn't. It was actually whether or not their partner ejaculated. That was a measure of successful sexual encounter. And number 2 was whether or not they encountered pain. And it's just a little sad that that is the bar that is set for women, as not all women, but for some women, around what a successful or satisfying sexual encounter looks like.
Yeah, absolutely. And that's what I would see in our practice, is that most of the women we see presenting with sexual dysfunction is pain that's driven them there. And so we're getting through that bare minimum of a positive sexual encounter for it to be pain-free. And then I think you would agree that is the bare minimum. We want women to be experiencing a lot better than that.
Yeah.
So along with that sort of fear, tension, relationship, that comes into like the first sexual experience being painful is a really negative starting point. So if that first sexual experience has been painful and you find yourself apprehensive about the next experience, you're actually feeling quite anxious about it, it's very unlikely to be a positive experience.
That's right, because that's how the brain works.
Yeah.
The brain does not motivate us to move towards pain or things that it deems is not useful for us or motivating for us. This is why pain and desire, we need to understand how that works. There's no way that we're going to desire something that causes us discomfort.
Yeah.
We have that alarm system, and this is why we have conditions like vaginismus.
Yeah.
That involuntary contraction that happens.
Yeah. And if you think about the hormones associated with desire and orgasm and pleasure, the dopamine and the oxytocin, that is the exact opposite of what our body is giving us if we're experiencing stress, anxiety, those sort of things, which unfortunately is a huge part of the emotions that you go through in that first 12 months. And so women that are sleep deprived, that are stressed, that are having relationship concerns, financial concerns, all that sort of thing, their dopamine is low and their cortisol and adrenaline is high.
Right.
And so they're much more likely to be experiencing pain responses rather than pleasure responses.
That's such an important thing for women to understand and to actually normalize that for themselves, that that's the state of being a new mother.
Yeah.
And probably the only pleasure you do get is sleep or perhaps breastfeeding, if it's a pleasurable, if it's going well.
Yeah.
And at that, being a new mum and post-birth, there's not probably a huge amount of pleasure in our lives. When we're talking about desire as well, it's not necessarily a lack of the right hormones. It's about whether or not we have any pleasure in our lives and whether we move that towards that or not. And when we're stuck in a state of stress where we're busy and we've got tasks to do and things to do and routines to keep, it's very hard to invite that pleasure into your life.
Yes, and very hard to switch from that day-to-day mode. And when we're talking about establishing pleasure and intimate satisfaction, then you need to build on that through the day, I think. So anything that you can do to introduce feel-good hormones into your day, things that are going to give you that dopamine spike, whether it's, sitting down by yourself and reading a book for 10 minutes or something like that. And
piece of chocolate.
Yeah, piece of chocolate, things that are going to raise your dopamine and lower your cortisol are actually really essential parts to having.
So you're saying doing that is quite important to help manage your pain responses.
Yeah, for sure. And to manage your pain, we know people with chronic pain, and if the sexual pain has gotten to that point where it is chronic, where it's been around for 6 months, you need to interrupt that hormonal cycle. So anything that you can do to get that dopamine spike in your life and to reduce your cortisol levels is really important. So meditation and deep breathing and doing things that you find, really enjoyable and really pleasurable is essential. You can call it part of your rehab. That's what you need to do.
Well, I was thinking I might just see if I can open. There we go. All right, fantastic. So I thought I might just share some of the points here, because a lot of times when we're tired and exhausted, and we're going into this new role of becoming a mother, why are we bothering to talk about sexual health and having sex? Like it seems like a ridiculous conversation to be having. But look, to be honest, sometimes people feel it's a ridiculous conversation to be having in life in general. And I'm glad that you say this is not a place we live in. This is not where we exist all the time. It's a place that we visit for pleasure, for connection, for our relationship, for enjoyment, for fun, for playfulness, for eroticism, for lots of different reasons. But we don't live here. But we do need to sort of be able to foster it, I guess, as a place that we can visit. So why are we talking about it? Because sex and sexuality and sexual health is a part of our life drive. It's an eros drive. It's a life thing. It's not a death drive. And it's very important to us as part of us as feeling like we are alive, to be able to have passion with somebody and connection and positive physical experiences. The other thing is, when it's going well, it's actually not much of a problem. I think when I speak to people, when their sex lives are great, it probably makes up 5% of the relationship. But when it's not going well, it seems to infiltrate every other areas of the relationship and their lives, self-esteem, body image, relationships. It's important because it really is about our core beliefs. What are we instilled with from kids around our core beliefs around sex and sexuality? Is there shame? Is there religious overtones, cultural overtones? We need to understand what are the things that drive our approach to our sexuality and our sex lives. How we feel about ourselves and our body and our relationships is really important. It really determines how valuable we see ourselves to society. You know, fertility, infertility, struggles. You know, women post-menopause are often saying, well, you know, I'm done with that. You know, and I can go be the crone on the hill, the wise woman in the cave. But it really does affect how we see ourselves as a value to society. It affects our perceived value to others and ourselves. As I said, it's flexible and it's changing depending on the life course. And I suppose we're looking at a micro, you know, moment here about becoming a parent. And what happens during this particular phase.
Yeah.
So we want to support people to do that.
It is such a small season of your life, but when you're in it, it is overwhelming and it feels like it's going to last forever. That's probably something really important, like the hormonal stuff that we're going to talk about as well. It's very short term, and like most of the sexual pain conditions we see, there are short term and they are resolving. You just need to get through that short period in life.
That's right. That's right. And I think some of the other points here to consider for all of you out there is, what was your sex life before you fell pregnant? You know, some people go, oh, before kids, it was great. Was it really? You know, we need to check in and say, maybe there were a couple of issues or things happening before even pregnancy. Of course, if there's things that have happened since having kids and pregnant, which there absolutely will be, we can look at that. The other question to consider is, what role does sex play for you in your lives and your relationships? We were talking about this before. During your life course, you know, in the beginning, in your teens, it's excitement, experimentation, power dynamics, getting into relationships, then maintaining relationships, and then, you know, getting married or long-term relationship, conception. Absolutely, there's a goal there. And then after conception, what role is it going to play in your life anymore? And unless we've already, you know, sometimes if we haven't had a real good start to that sexual development around pleasure, self-soothing, getting to know your body, good orgasms, the role can seem a little redundant. Yeah, absolutely. So we do need to look at that. The research shows with the female sexual distress scale, it's sort of like an assessment. A lot of women who do this sort of self-assessment say the distress that they feel is not necessarily about a dysfunction or a pain condition that they're experiencing. The distress is more about how it's affecting their lives and their relationship and how they view themselves. And so we don't always have to focus on dysfunction or illness, or, you know, we look at how's it affecting your life in other ways, and how can we maybe approach those issues from a different perspective. You're talking quite a bit about pain today, so I won't go into more about that. I might leave some of those as well. That's probably more your area. Did you want to continue?
Yeah. So if we're talking specifically about postpartum and the kind of conditions we see post-pregnancy and post-birth, one of the big ones that does come up a lot is prolapse. So if you're watching and you haven't returned to sex yet because you're concerned you've been diagnosed with a prolapse, or you feel like your prolapse is going to impact on your sexual life, I think it's really important to establish that it's not. Most women report that their prolapse does not affect their sexual satisfaction, sexual pain, anything like that. So you can have a very, and the other important thing, I guess, is that the partners report no difference as well. So I think reassurance is a big thing with that. There is one particular type of prolapse which can be a little bit more of a concern. I'll just quickly show you a diagram where we have what we would call a normal anatomical position, where your uterus in the middle there is sitting quite high. Usually gives you about sort of 7 to 8 centimeters of the vaginal canal. And even if you have a mild uterine prolapse where you don't necessarily have any symptoms, and you might not even know that it's there, you might just be lacking a little bit of space in that vaginal canal. And then if you have a more obvious, you will definitely know that it's there. You'll probably be experiencing some kind of heaviness or bulge, but you can see how the space available for penetrative sex is significantly reduced. But there are lots of things that we can do about that. And so positioning is really important, and you want to use gravity to your advantage, but something as simple as changing your standard missionary position to having some elevation under your hips can help increase the cervix height and make things a lot more comfortable, or controlling the depth of penetration can be really helpful as well. And there is a nifty little device that I thought that I would show you. And this is not just for prolapse, this is for anyone who's experiencing a deeper sexual discomfort, which is called an O-nut.
Right.
It's so good, and it's so cheap and accessible, and it can make such a world of difference. And it might not necessarily be something that you use forever, but it can be something that for a short-term period makes sex a lot more enjoyable for both yourself and your partner, just taking that pain off the table and re-establishing sex as being a positive experience instead of worrying about it constantly. Is this going to hurt? Is it going to be too deep? So you have this stacking mechanism of rings that controls the depth of the penetration. The other thing that I thought I'd quickly show you in regards to prolapse is a pessary, which you may or may not have heard about, but we do use these little silicone devices, which is super soft and pliable. They look a little bit intimidating, but it's basically designed to lift the height of the cervix. And this particular one I'm showing you, the ring, can be used during sexual intercourse. So you pop it in, you forget that it's in, you don't need to remove it for sex, and actually gives your cervix that little bit more height. So you're not getting that sort of deeper discomfort with penetration.
And so is that something that people can do on their own?
So you do need to have that fitted. So that's something we would do as pelvic physios, or gynecologists will fit them, but really helpful for prolapse symptoms. But yeah, also for those people where the reduced cervix height is an issue. But this is where assessment does come in, because you could be getting that deep kind of block penetration because of the scar restriction we were talking about, because of having a really high tone pelvic floor, or because of having lost some height of your cervix with a uterine prolapse. So really need to figure out what it is that's causing your symptoms, and then look at what the most appropriate management is going to be.
Great. I think maybe people don't realise how much physiotherapists do.
Yeah, particularly in this sort of scope. And even as a physio, I worked as a physio for 10 years before doing pelvic physio, and I would have no idea that we do things like this, like pessary fittings and all that.
It's a specialist area, but the pelvic health, pelvic physio is
Yeah,
a specialist area.
yeah, for sure. We did touch on hormones before and how important like those positive experiences are for fostering like those positive hormones. But the other thing, we started talking about breastfeeding, and to have appropriate milk supply to lactate, we need low estrogen. So all breastfeeding mothers will have low estrogen, which is essential for your breast milk supply, but it's also a really important hormone for vaginal tissue health, for vaginal lubrication, for vaginal mucosa. And women that breastfeed for a long time, or that have low estrogen for other reasons like the hormonal contraceptive or perimenopausal, will actually see what we refer to as vaginal atrophy, which I hate that word, but it's basically a thinning and a sensitivity of the tissue around the vestibule, around the entrance to the vagina. And so that's something I feel like, which is the typical postnatal pain doctors talk about, and they say, have a glass of wine, grab yourself some lubricant and you'll be fine. So I think that's probably the most common assumption of why women are getting pain, is because they're lacking lubrication. And yes, a good quality lubricant can be really good, but even if you're putting a lubricant over dry, dehydrated tissue, it's basically just a barrier cream that isn't going to last very well. So vaginal moisturizer can be really helpful. I mean, if your skin is dry anywhere else on your body, you put moisturizer on it. So you can do exactly the same thing with a natural oil-based vaginal moisturizer. And trying to improve, you get this real sensitivity and atrophy around that entrance to the vagina. And that's where things like a dilator or a pelvic wand can be really helpful. So if you're really experiencing a penetration pain at the entrance to the vagina, we can use different devices. I'll just quickly show you these sort of things, because I think they just look so intimidating, and they're really not. You could start with quite a small dilator. Again, it's a really soft silicone material, and you're basically just trying to stretch the tissue. So again, you use a lot of lubricant. You're doing this in a calm, safe environment without the time constraints and the partner constraints that might be associated with having sex with your partner,
Right.
and you're just trying to get some more extensibility and space with the tissue.
But now there's lubricants and there's lubricants.
Yeah.
So I know you're saying natural one.
Yeah.
I mean, you're talking olive oil, you're talking fractionated coconut oil.
Yeah, I actually don't mind just using natural coconut oil, but if you're using straight oil, you will tend to find that it disappears quite quickly. There's a few great Australian companies that make a really beautiful oil-based lubricant. So Olive in Bee is made out of olive oil and beeswax. That's amazing. The beeswax gives it a bit more longevity.
Wow.
We stock Yes Organics, which
Mhm.
makes a really beautiful oil-based lubricant. It also does a great vaginal moisturizer. The issue with an oil-based lubricant is that you can't use them with condoms.
Yeah.
With the latex. So you do need to use a water-based or a silicone lubricant, which there are some great Boobalube is really good as well.
Oh, wonderful. Yes.
Yeah. The water-based lubricants are probably my least favorite because they just have a really thin texture that just disappears quite quickly. I find you need to reapply. But if you are using condoms, they're one of your best options, but you can try the Boobalube as well.
I think lubricants are really underrated.
For
And
sure.
it's such a way to increase pleasure and sensation and ease and it's fantastic all round, not just for functional.
And I see a lot of women, I say, using a lubricant and they say, I don't need one. And I say, well, just try it and then let me know if you, just that enhancement, the ease, just a different experience, particularly in that pregnancy and postnatal period where your hormones can be a little bit all over the shop.
Yeah. All right. Fantastic.
Yeah.
So those are all good. What was this one for?
So if we're talking about the tension around the actual vaginal entrance, a dilator is a really good option. If you're suffering more from a high tone pelvic floor muscle complex, so if we imagine the whole pelvic floor muscle covering the base of the pelvis, if the whole sling is sitting quite high and quite taut, and if you've ever had a glute release by a physio, you know the feeling like that elbow in your bum trying to release your glute muscle. It's a similar feeling sometimes with penetrative sex against a tight internal pelvic floor muscle. It can be really uncomfortable. So if you don't like the idea of releasing internally with a dilator, and that can be a big leap for a lot of people and something to build up to, particularly if they've had a pain experience for some time, we often start doing an external pelvic floor release, like with your typical massage trigger ball, just rolling along the inside of that bone that you sit on, your ischial tuberosity. So if you find that fleshy spot between the bone that you sit on and basically your perineum, you can get a nice muscle release through the pelvic floor. And that's a really nice starting point for a lot of women to get that desensitization, get that muscle release. And it might be the starting point that then allows a physical exam or the pelvic floor physio to do some internal release work. And then they might feel comfortable building up to using either a dilator or say a pelvic wand at home. And this is one of my favorite little tools for pelvic pain. So cute. So it's a fantastic way for looking at the vaginal model to get that little bit deeper, to get that release happening. So you can control with the arch of the wand. It's specifically designed to be able to get to those deeper trigger point parts. Fantastic not only for sexual pain but also for women who have chronic groin pain or glute pain and they're not getting that internal release. And you can do that stretching, that scar tissue massage we were talking about with the wand as well if you're finding it just physically really difficult to get there.
Okay.
So basically the whole idea of showing you all these things is not so you necessarily just jump out and buy one and play with it, but just to let you know that there's so many different options out there. Each form of sexual pain is quite different. We want to get to the bottom of what's causing it, and so what is going to be the best course of action to address that. Is it muscle tone? Is it scar tissue? Is it sensitivity? And all these work a little bit differently to make sure that we can address that.
And I think the knowledge around this area has grown so much in the last 15 years. Just even focusing on women's sexual health has grown in the last 15 years. So we know a lot more than we ever have before. I don't think vaginismus or vestibulitis or vulvodynia was even really things 15 years ago. So now we know. And, you know, there's a lot of women living with endometriosis and adenomyosis and the sort of recovery from that. So you guys are so well equipped, and if people can just reach out and ask for help is the biggest thing, because I think a lot of this stuff is great when you just had a baby. To put another thing on your list of things to do may not be your priority at the time, and that's okay. We don't want to be putting extra pressure on ourselves to meet this bar that was, or that, you know, social media is saying that we should be meeting, about, you know, get your baby body back and get back in the sack, and it's too much pressure.
Yeah, for sure. And it just adds to the issues then. If you are feeling that pressure to return to sex before you're mentally and emotionally feeling ready,
physically,
it's probably not going to be great. And that's really my purpose in doing this, trying to target women who might be in the first year postpartum, because we often see women 2, 3, 4, 10 years down the track who have been experiencing sexual pain, whereas if they could have maybe held back a little bit longer initially, or they could have addressed these things initially, it is more temporary and it is more tissue healing based. Whereas if you get into that chronic pain response cycle, it's a lot harder then to address, and you have that whole neural connection that you have to desensitize. So yeah, there's absolutely no harm in waiting. If you've had your 6-week check, that does not mean you need to or have to return to sex. You have to be physically, emotionally, mentally, relationship wise, everything has to be in place for it to be, I think, a positive thing.
So what I might do is just bring back that slide, just going back to some of the more psychological and emotional things that we might be dealing with. Just slide through here. When you're noticing that things have changed and you're not feeling the same that you were before, you know, there might be a bit of grief around that, but we want to sort of approach things from 3 different perspectives. And Erin's definitely a part of looking at the biological and psychological and emotional support for the clients that you see. But we're looking at what type of birth you've had, what are the medications that you're on. You may be experiencing some postpartum depression, and then they just wake you onto SSRIs because the baby's most important. And of course, that's going to have an effect on your sexual desire and sexual functioning and libido. And you've been talking a lot about the impact of pain and hormones. Are you dealing with any sort of other illnesses or diseases? I was talking about the antidepressants, SSRIs and SSNRIs. Some of them are actually a little bit helpful though, which we'll talk about in a minute. Obviously your diet and your gut health is very important postpartum as well, and your healing recovery, and any sort of biological dysfunction, you know, like injuries to the pudendal nerve, which I'm not sure if you've come across or receive it of.
There are a few tractioning injuries to the pudendal nerve with a very long second stage of labour tends to be the most common way, and the pudendal nerve innervates your clitoris, so it can affect, it's one of the big things that we see with women with vulvodynia, which has had a birth onset, but then it can also be related with sexual function in a more subtle way if you've had a change in that sensation around that area. And things that we see talking about medications and diet and gut health, if you've had mastitis and you've had recurrent antibiotics is a big one, or if you've had UTIs and you've had recurrent antibiotics for that, and you end up with thrush, you end up with really poor microbiome in the gut, but then also the vaginal flora is affected as well. So trying to establish that really healthy environment for both the gut and for the vaginal flora, like probiotics, they're really, really helpful, but you need a specific women's flora probiotic for that vaginal tissue health.
Okay, all right, good to know. I think one of the biggest changes is to orgasm, and a lot of women may just put that down to the type of birth that they've had, but you know, there could be many reasons why that pudendal nerve gets affected. So don't just go, oh well, you know, it's because I gave birth. There could be an ongoing issue or pressure, or there could be a bit of trauma or something putting pressure on the nerve. I even have women who experience massive headaches after orgasm. It's so complex what can go wrong. psychologically and emotionally, there's huge changes to your body image and how you feel about your body. Of course, it's a wonderful thing that your body's been able to do, but some of us might not be so happy with the side effects, what they don't tell you in the book, what to expect when you're expecting.
Yeah. It's a very messy period. There's breast milk and there's blood and there's discharge and there's all these things that you might not be used to in your pre-pregnancy life.
And it's not your own. It's not your own body anymore. It's not the same body that you had before you fell pregnant either. And of course, we're talking about a bit of postpartum depression that can come in. And I often see clients with adjustment disorder to motherhood. There's a huge grieving process about the loss of who you were before and the kind of life that you were able to lead, and that can also happen for your partner, and that can affect your relationship, which leads to a bit of depression. I'm just going to let Caitlin in here. And I find, and of course, when you're touched out breastfeeding all day, it's really hard to now at the end of the day want to go visit a space where your boobs are going to be caressed by your partner when you're all touched out, And this is what comes into couples work about being able to negotiate with your partner. We're so focused in the Western world about penis vagina penetration as the only measure of having had sex. Negotiating a toolbox of things that you can do as a couple, because where you're at becoming a new mum might be pleasure for me is a nice warm bath with some candles. And then, pleasure for your partner might be being able, you hold your partner while he masturbates and can go to sleep after that. There's so many other ways that you can remain intimate, but we get so fixated on the one and only way to have sex.
What we're talking about purpose of sex, it's the purpose of your body changes also, and the function of those boobs that were once a sexual thing are now a very practical, life-giving thing, and you have to change your entire mindset of what your body is now capable of.
That is so true. And I think couples who've been going through IVF, fertility treatments to fall pregnant, and it's the enjoyment of sex has gone out the window. It's just become a medicalized,
very clinical,
functional, very clinical thing. And to try and step back into that nice, fuzzy, romantic sort of space with it, or erotic space with it, can seem counterintuitive. This is why some of these core beliefs are important. Are mummies allowed to have erotic sex anymore? Well, of course you are if you want to, but we may struggle with some of that identity with ourselves. But I'm now a mother, I should now be a responsible adult, and
not allowed to do that.
Not allowed to do that anymore. Trying to struggle with that role, your own sexuality. Conflict management. Everybody's full of stress and getting no sleep and full of adrenaline and cortisol, and adjusting to all these changes. There's going to be conflict in your relationship, and it's really important for couples to know how to manage that conflict and have strategies around that. When I was talking earlier about what was the sex life beforehand, if partners have experienced sexual dysfunction, say we have, and I'm being very heteronormative here around talking about men and women, but when men may have previously experienced, loss of erection or erectile dysfunction, or maybe even delayed ejaculation or premature ejaculation, and those sort of things haven't been resolved within the relationship, it can be a bit of a barrier to getting back to that sexual relationship. So this is very much a couple's, I don't want to say issue, it's a couple's conversation and a couple's negotiation, absolutely. Look, the type of sex, I can't tell you how many couples I see, and they're going, yeah, no, we're having sex. And I say, but are you having the kind of sex you want to be having? And then there's just crickets. So we want to be, as part of that conversation, are we having the kind of sex that we want to be having that is pleasurable for both of us, where we both feel like we have power and agency in our sexual relationship? And what do I mean by that? I mean by, do you feel as a woman that you can say no if you don't want to? Can you say no if you start cuddling and going to passionate kissing? Do you feel like you can then say no and say, that's enough for me? Some women don't feel like they can, and that's why any kind of affectionate touch, sensual touch, even sexual touch falls away, because women are so terrified of giving the green light, as it were. And of course the partners are hoping for the green light or, you know, trying to get the green light. And I think that really puts the brakes on quite hard for a lot of people. We want to be able to say, look, just because we have a passionate kiss doesn't mean it has to lead to sex. But I think in Western culture and the way that we typically have sex, that's the expectation. The sexual patterns in relationships, you know, what is the step 1, step 2 that sort of leads to that? And we might start to avoid those steps, even sitting close on the lounge and watching a movie, and try and come up with some new patterns or new ways of engaging with each other with intimacy. Intimacy doesn't have to be sex. Intimacy is going on a hike to the top of the mountain together and go, wow, look at what we did.
Yeah.
When you just had a baby, intimacy could be being able to fold the pram and putting in the boot of the car together. That could be the achievement as a couple.
And I think that's so important in that first year is, what do you guys do together that fosters a really intimate connection? What can you do that you both enjoy doing together, that you can have that moment? And whether that's penetrative sex or not, that might be a facet of it, but there's plenty of other ways, if that's not on the cards at the moment, of other ways of fostering that sort of intimacy.
Totally. Intellectual conversations, good debates about what's going on, or spiritual intimacy, or there's lots of different ways that we can feel connection that reminds us that I see you, I'm with you, I'm by your side, and we're connected. Those rituals of connection with couples are very important, even when baby comes along. They may change and adjust, but you know, these are conversations that I have with couples all the time. So renegotiating that intimacy is very important. And there is nothing sexier than consent. There really isn't. When you say to somebody, I really love a hug, and they go, for sure,
Yeah.
you know, and then you're both in it together, there's nothing more sexy. So part of this renegotiation could be around, how do you bring consent into the relationship and make it sensual? And that's discussions that we have as well, because it really can be. I'd like to touch you like this. How do you feel about that? I'm in.
Yeah.
Go
And I
for
guess
it.
it's a way of starting the conversation as well. And where does that conversation lead, and getting to know your partner's wants and needs. And
And I think what happens with couples often is I see the tit for tat. Who's suffering the most? I'm suffering the most. I'm so tired. You have no idea. Well, I've been at work all day, and now and it becomes, and it's really it erodes the relationships away. So this relationship social side of it is important, but we want to cover all three to get you to the new you and the new relationship, the biological, the psychological, the relational, and the social. So one thing I did have here was a couple of things on medications. Now, I'm not a doctor, please no, but this is just some of the stuff that we know is on the market. So Addyi is a testosterone-based medication in the States. It's not approved here, really sorry, but it's not. But sometimes testosterone can be very helpful around desire. If a pharmaceutical company could have invented a pink pill to make women desire sex a lot, they are scrambling to find that pill. But it's more complex than just giving a woman a medication. There's no magic pill. The bupropion and the Wellbutrin is available in here in Australia, and it has shown in some case studies to improve sexual desire. The fluoxetine helps with, if you lower the depression, if you work on the depression and lowering the anxiety, the sexual desire or the want for pleasure comes back. And the peptide, the bremelanide, is not available here. That's in the States, but that has shown, unfortunately, that has been shown to significantly improve sexual desire-related distress in premenopausal women with hyperactive sexual distress disorder. So there are a couple of things, but there aren't any magic ones out there. Hormones,
Yeah.
really important for you.
And I think
Caitlin, if you could just put yourself on mute, that would be great.
It's very complex, isn't it? Women's sexual arousal and desire, I feel like, is far more a mental, emotional, hormonal game than necessarily men's, which tends to be a little bit more physical. You can correct me on that if I'm wrong.
No, that's all right. I don't want to stereotype men.
Yeah.
I've seen plenty of men with low sexual desire.
Yeah.
Lots of men struggle with that as well, related to anxiety and relationship issues and things like that. But I do think it is more complex for women, because we need certain factors in place for us to feel like we can visit that place.
Yeah. Yeah.
So here are just a couple of things which I think I touched on earlier. The most common issues are the decreased libido, the difficulty achieving orgasm, and pain after birth. Does usually resolve within a year, but if it doesn't, then seek help. There's plenty of people out there. I think a good conversation is to understand the difference between desire and arousal.
I was going to actually ask you about that, so I'm glad you're talking about that.
A lot of us are trying to reach some sort of understanding of how often we should be desiring sex, and why don't I just want to have sex like I used to when I was 20. Look, what I say here is desire is a wanting, right? When you think I want pizza, right, you think I want it's a drive, it's a dopamine response that, oh, when I had pizza last, I really love pizza, I really feel like pizza, I want pizza, and you can't get it off your mind until you have pizza, right? It's a wanting. Then what happens is the arousal happens. If we look at the sexual response model, you have desire, and then you engage in some activity and stimulation, and then you start to feel the arousal, and you feel, oh, I like this, I'm liking this, I'm enjoying this, and you have the arousal. So the arousal is the liking. Kind of like going to the gym. Not many people really want to go to the gym, but when you go and you get yourself through the door, you get there, and then you're on the treadmill, and then endorphins start coming, and you're panting away, and you're like, wow, this is great, why don't I do this more often? Because you're liking the arousal that you're feeling from that exercise.
But you didn't necessarily have the desire to do it.
You didn't have the desire to do it. So we don't have to have the desire to engage in sexual activity, but I'll preface this with, we do have to have consent. Our own consent. If you keep stepping over your own boundaries, sex turns into a chore, and you keep feeling violated, basically. So desire is the wanting of the thing, and that is very much based on previous experience and levels of stimulation, arousal, and whether or not it's worth it, the motivation price. But that can be spontaneous. Oh, I'm horny. Oh, I feel like I could, have some sex. Or it could be responsive, going to the gym, and then the arousal happens, and then the desire comes. So if you're putting yourself under a lot of pressure to want to have sex, which is what I hear from a lot of clients, don't. Responsive desire is good enough, but we've got to want to turn towards those possibilities. We want to, be able to turn towards opportunities and possibilities rather than putting the brakes on straight away. So I've covered a bit of that here. The brakes and accelerators idea is based on inhibition and excitation models in our brain. If I said to any of you out there and us, what are the reasons not to have sex?
Well, pain would be a big one.
Yeah.
I can't think of heaps.
Not to put you on the spot there. Oh, wow, I'm bloated, I'm tired, I don't have enough time, I've got other things to do. I'm anticipating pain, I haven't shaved my legs, it's coming up to that time of the month, I just don't feel, you just want sex, you didn't help me out yesterday, I'm not going to help you out now. We can just go into the brakes really easily. Because the brain is designed to conserve energy and take the path of least resistance. So expect the brakes. They're going to come. What we want to know and focus on as well is the accelerators. What are the reasons to go there? Why? Why would we want to go there? And I think a lot of people struggle more to answer that question. Because it feels good, because I want to connect with my partner. I feel a bit younger and carefree when we're in that space. I'm not worried about anything else when we're having sex. Those kinds of things. We want to know what the accelerators are and how it feels after having engaged in the sexual activity. Given that it's pain-free and there's no sexual discussions or issues like that, how do we feel afterwards? So that we're not so focused on the brakes that will deter us from going into that activity in the first place. If you're with your partner and when you, I remember looking at my husband from afar and going, gee, you're kind of hot. But I would just think it. What we want to do is actually say it. We want our partners to feel like we've got a simmer going, where we can hold hands, where we can flirt. We stop flirting, where we can be playful, where we can kind of just keep a simmer going in the relationship so that when we do want to visit that place, it's not because we're coming from ice cold.
Coming from cold turkey.
And you kind of touched on that a little bit earlier.
Yeah. That foreplay starts with whatever is going on in your day and how you've been feeling and how you've been interacting throughout the day.
Yeah, foreplay starts after the last encounter.
Mm.
This is what people say.
Yeah. It's funny, I'm getting advice from Matthew McConaughey, but I heard him on a podcast the other day and he
I'll take
said,
advice from Matthew.
he said, sometimes I don't feel like having sex with my wife, but I know that dinner is going to taste better, I'm going to sleep sounder, and we're going to cuddle harder. And so it's all that aftermath that sometimes you're doing it to foster that positive experience that you get from sex, even if you're not feeling particularly like it's on the cards at that moment.
And so that might lend to that responsive design, is that you don't really feel like it at the time, but then once you're in it, you're there.
All those positive things.
All that positive, and then you're feeling great. You sort of afterwards, you're right. And so if anybody here has their partner with them who's been listening, I really want to stress recovery from having from birth and bringing a child into your world with your partner is absolutely a couples thing. And I can't tell you how many times I've had women arriving saying, my husband said I had to come and see you. And it's not fair because things have changed for both of you. And as a partner, a male partner, perhaps as a new father, it's also an opportunity to put your story forward and to say what's happening for you. Because a lot of the time, this is where the disorder comes in. The assumption is his life is just carried on as normal. He's fine. His body's fine. And there's resentment around that. But this is an opportunity for men to really go, look, I'm not doing this pain-free. I've touched on keeping the simmer going. And the myth, I would like to close my part of this talk with this. The myth around when we first met, things were great. Before kids, things were great. There was, yes, when we first meet, there's that limerence period or that honeymoon phase where we're basically high. It is a great phase, but we're basically high, and all of those hormones are drawing us together to bond. And then nature reckons 6 to 12 months you should be pregnant, and you can go off and impregnate someone else. That's how we're designed. We're not designed for these long-term monogamous relationships. So we get together, we bond, have lots of sex, and then you get into a long-term relationship and have to sustain that. And the fallacy is that was so easy. Why was it so easy? Why did it just happen at that time? Well, we were high, but also we've forgotten how much effort we put into that time. We planned dates, we made phone calls, we sent sweet texts, we said please, thank you, and we're very kind to each other. We, dolled ourselves up and put on sexy lingerie, and we put a lot of effort into what was supposedly organic and just happened naturally. You keep putting that effort into your relationship, you will sustain a happy, close, and connected relationship.
Yeah, that's so important. I got so much out of listening to you talk then, Nina. It's so amazing.
And vice versa.
I was just going to quickly check if anyone has got any questions.
Any questions? Yeah.
So if anyone does have anything specific that they wanted to ask, we've probably got a few minutes before we log off. So you can unmute if you want to, or you can pop something up in the chat if there's a specific condition or something that you wanted to talk about.
It's been so fantastic to have so many people logging in on a 7 o'clock on a Wednesday night. So.
I know, I so appreciate everyone coming, but like we said, I think that is just a testament to how important this topic is, how much of a sense of yourself you lose in that postpartum period, and how sexual health is such an important part of your overall well-being. Is such a big part of us, I think, that we diminish, and it'd be nice to devote a little bit of time and energy to, which you guys have tonight, which is so nice. So we are always available, so you can contact Nina or myself on our social media or through our websites, Territory Intimate Relationships and Health.
Yeah, Territory Relationships and Intimate Health, or Pelvic Health Newcastle. We've both got websites, and Erin, you're with Female Focus Physio.
Yeah, absolutely. So reach out if there's something that you don't feel comfortable sharing tonight and you want to talk about it, or if something has really resonated with you and hit home, like a small part of the talk, and you want to elaborate on that and really delve into it, it's probably best to make an appointment.
Just send us an email, yeah, we'll make an appointment.
Yeah.
I've got a question. How long after massage of an episiotomy skull will you see a difference in pain?
Well, I think you can see a difference within one treatment. I've had women with sexual pain and we've done a scar release in the clinic, and the next day they've had pain-free sex. It's more a desensitization at that point than anything else. But honestly, within one session, you can notice a little bit of a difference in the tissue. And so for older scars or really significant scars, you might have to do it more consistently. But, you know, twice a week for a couple of weeks, and you'll notice a huge difference. And then it might be something that you have to revisit every now and again as the scar matures and changes.
Yeah. I'll just say as well, so Erin and I will work quite closely with clients, and I have a device here called an Emsella chair, and it is a device that, you know, 6 months post-birth, if you're noticing mild prolapse, mild incontinence, stress incontinence, urgent incontinence, the Emsella chair is a TGA-approved medical device to help with laxity in the pelvic floor. It's not for women with hypertonic pelvic floors, and I would always suggest to go and see Erin first to have a pelvic floor assessment before doing the Emsella chair. You can Google it up and get some information on it, but it's great because you just sit on it fully clothed, you get your treatments, and you walk out. So
and that's one thing we didn't touch on is outside of prolapse, how some laxity or some weakness in the tissue can affect your arousal and orgasm particularly. And so the Emsella can be really helpful with that. The product that I recommend for vaginal dryness, I think I have one here, this is the one that we stock in the clinic that I really like. It's a Yes Organics vaginal moisturizer. They're about $20 for the tube, and it's all natural ingredients. It's got like aloe and coconut oil, really lovely ingredients. If you are long-term breastfeeding, if it's more a hormonal deficit, you may need a prescription estrogen gel, but that's for your doctor to prescribe. But as a simple, very minimal side effects, and you just want to try something for a little bit of extra dryness, the moisturizer is really, really nice. So if you're feeling some kind of irritation, itchiness, if you're getting little grazes or splits in the labia, or if you're having sexual pain, this is a great go-to.
good to know. I need to get some of that in this office.
Yeah, that's a really good one.
Is the one the best device to use if massage of an episiotomy scar with your fingers isn't something you feel over comfortable doing?
Yeah, that's a really common question we get with perineal massage during pregnancy, but also with scar massage afterwards. There is the option for your partner to do it. And again, that's a conversation you need to have, because like we were talking about, if you've had a period of time where sex has become quite clinical, it's another way where you're kind of clinicalizing this intimate sort of interaction. So whether you feel comfortable with your partner doing it or not is entirely up to you, but you can use the one to do that. One of the best things that we were kind of talking about is to use just the tip of it to do that stretching motion. So you just kind of pull down on the stiff tissue. I don't know if you guys can see that, but it gives you that.
So that's
extra
not bendy.
length.
That's it's quite sturdy.
It's really sturdy, but
it looks like a thing you can bend.
No, it's stuck in that shape, which is specifically designed for the reach.
Okay.
But if you hold it this way up and put a little bit of pressure down, and you can control it that way, and it extends your reach. It is a little bit hard to maneuver over the scar, because what you want to do is have that really small, firm movement over the scar. So you can definitely try the wand if you're having trouble getting there, but I would say play around with different positions as well. And you might be able to find that you can use your finger if you get into the right position to do it.
Okay. The one model that I didn't hold up, which I probably should, is a very, very important organ that we have, which really we don't understand any other purpose for it other than pleasure, which is fantastic. So this is a 3D printed life-size model of what your clitoris looks like. Now, if I hold that in my hand, a lot of women actually have no idea, but that's quite a large organ. And you might be saying, well, I don't quite know, how does that fit or how does that look in my body? This is an engorged clitoris, right? So this is when the blood flow has gone into the crura, and this would have been the glands. Had you been a boy, this would have been the glands or the tip of the penis, and this little bit here is the bit that sort of sticks out that most times we're stimulating externally. So your model here, yeah, so if this is your urethra at the top here, and this is your vaginal opening, the clitoris usually, your vagina's a bit bigger than my clitoris, yeah, normally straddles like that, and this little bit would be sticking out on top, okay, probably about there, but this model's too big, sorry. And so when we're talking about orgasm and when we're talking about pleasure, it is all clitoral. The search for this G-spot it doesn't exist. It's all clitoral. And how it happens, you can stimulate this external part for an external clitoral orgasm, or it's how the penis displaces the crura here as the penis goes into the vaginal opening and displaces the crura. That is how the stimulation and the pleasure comes for the clitoris to have a full clitoral orgasm. That's kind of what you're going for. Just for a bit of FYI, in case you didn't know how big and how wonderful this is.
Even I was surprised at the actual 3D model, how big it is.
Yeah.
Because I think women struggle also with the pelvic floor because it's a part of your body you can't see. Usually if you're working on rehabbing something in your body, you can see it, you can feel it, you can touch it. And these sort of organs, there's still a whole lot of mystery surrounding them. I think you can't see them clearly, you can't talk about them openly necessarily. So you need to demystify the...
Well, Helen O'Connor, she was the first Australian female urologist, and she did the first proper dissection in 1995, I think it was, which is not long ago. And the clitoris actually fell out of the Grey's Anatomy medical book, the manual, in 1948, disappeared, was not a part of the female anatomy, and has only recently come back. So I'm glad that it's come back and that we're learning more about it, because it's a great thing to have.
Important. Yeah.
So it's heading about 8:10 now. If there aren't any more questions, then we might all sign off.
Yeah, beautiful. Like, reach out, like we said, if you've got any questions, that we appreciate you signing on, and hopefully I've definitely gotten something out of it, so hopefully you all have as well.
Fantastic. Thank you,
Awesome.
Erin.
Thanks, Nina.
Thanks, everybody. Have a great night.
Thanks, guys.